Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Your host, Dr. George Netto, is the editor-in-chief of Modern Pathology and the chair of pathology at the University of Alabama at Birmingham. Here's Dr. Netto.
Welcome to ModPath Chat. Today's discussion is with Dr. Nora Katabi. Dr. Katabi is an attending at Memorial Sloan Kettering Cancer Center. And congratulations, Nora, on the recent promotion to a full attending. Nora is a head and neck pathology expert with special interest in salivary glands and oropharyngeal tumors. Already with over 100 peer-reviewed publications, she is a second-time contributor, actually, to the 4th and 5th edition of the WHO Blue Book. We will be discussing her team's recent publication on the prognostic impact of extranodal extension in the setting of treatment-naive HPV-positive oropharyngeal squamous cell. Thank you, Nora, for accepting my invitation.
Thank you so much, Dr. Netto, for the invitation. It's a pleasure to be here.
I'm honored, and I know a lot of times I end up saying that I know the author very well, but in your case, the author was, I'm proud to say, was my resident a long time ago. Not that long. She's very young and done amazing. I'm so proud of your success. And I think this is a very impactful publication that has a potential to be practice changing. So I wanted us to discuss that. So let's start with, it seems like you're focusing on treatment naive, so no previous neoadjuvant therapy,
Correct.
and HPV positive oropharyngeal SCC. Tell me why this cohort specifically.
HPV positive squamous cell carcinoma, it's a distinct entity in head and neck cancer and head and neck squamous cell carcinoma. It has a different morphology, usually has non-keratinizing morphology. It has a propensity for nodal metastases, improved prognosis, and so it's a different and distinct entity. And extranodal extension, it's a well-known phenomena in cancer in general, like bladder, breast, and head and neck. And for HPV negative head and neck squamous cell carcinoma, extranodal extension is an important and significant prognostic parameter. It's already incorporated in the 8th edition of AJCC, and it's an indication justifying chemo, radiation, and adjuvant treatment. On the other hand, for the HPV-positive head and neck squamous cell carcinoma, the significance of extranodal extension is not well established. There are some studies showing that there's no significant association between extranodal extension and prognosis in HPV-positive squamous cell carcinoma, and there are other more recent studies that showed that there is a significance between extranodal extension and HPV-positive squamous cell carcinoma. So it's not well established. So we wanted to do this study to assess the significance of extranodal extension in HPV-positive squamous cell carcinoma.
I get it now. So that's why we're focusing on positive. And hopefully this will tip the balance and we'll know the ground truth again. So what was the cohort? Is this cases treated at your institution? How many? Can you tell me just briefly?
There's 232 surgically treated, treatment naive cases. Most of these were surgically operated in our institution. There is a small percentage that was operated outside, like Sloan Kettering, but we reviewed the material here and the patient managed here. Among these, for these 200 32 cases, we reviewed the pathology, like at least one pathologist reviewed the cases. And for the extranodal extension, we had a consensus meeting where three pathologists, myself, Dr. Ronald Gossain, Dr. Benshu, we reviewed all cases with extranodal extension to confirm the presence of extranodal extension and to measure together the extent of extranodal extension, because it can be subjective. It's not always a straightforward finding.
So I think that's an important point to clarify. So I see that you mentioned a vertical measurement, maximum vertical, maximum horizontal, and you define like a major E&E extension or not. Can you briefly describe for our audience how you do that usually in your practice? Because some of the audience are general pathologists like myself. So.
Yeah, sure. So for extranodal extension, we measure we measure the vertical span of extranodal extension, which is measured as a perpendicular measurement from the outside border of the lymph node capsule to the maximal area of the invasion in the perinodal tissue. And we also measured the extranodal extension span horizontally as a horizontal measurement parallel to the lymph node capsule. For the extent of invasion, or for the major and minor extent of invasion, when we did the statistical analysis, we found a 4 millimeter to be significant for extranodal extension. So vertical. We called vertical. We didn't find the horizontal span of extranodal extension to be significant or associated with the tumor outcome. So we focused on the vertical extranodal extension, and so based on the finding that 4 millimeter is a significant cutoff, we classified the extranodal extension into major when the extranodal extension measures a vertical extranodal extension measures 4 millimeter or more, and minor when it measures less than 4 millimeter. We also looked at the soft tissue deposit, and we classified them into two subgroups, like soft tissue deposit with well-rounded smooth contour. We consider these to be lymph node replaced by a tumor without extranodal extension. And the second subgroup is the soft tissue deposit with irregular contour. And we considered these to be or to represent lymph node that is replaced by tumor with major extranodal extension.
Excellent. So the perpendicular and vertical really referring to perpendicular to the capsule, meaning radial, versus horizontal parallel to the capsule. So it makes sense how radially, how much the tumor is extending. And I like the definition of the soft tissue. I'll take your word for it, that it's smooth. It means still within a node that is completely replaced. So let's move on to the findings. And of course, for the sake of time, I wish we could discuss every single finding. Tell me, what are the major findings here that you think are important for us to know?
The major finding is that we found extranodal extension to be a significant prognostic parameter in HPV-positive squamous cell carcinoma. So it's compared to tumors without extranodal extension. Tumor with extranodal extension, they do have a higher rate of perineural invasion, higher number of positive lymph nodes, larger primary, higher rate of adjuvant chemotherapy, and shorter follow-up. And also, when we compared a tumor with extranodal extension with a tumor without extranodal extension, the survival rate was different, and a tumor with extranodal extension have a shorter overall survival, disease-free survival, and disease and like recurrence-free survival. So the survival rate was different. The other major finding that we found that the extent of invasion or the extent of extranodal extension is important. And a tumor with major extent, like a major extranodal extension, did worse compared to minor extranodal extension.
Excellent. So really there is a dosage effect here. If the tumor extension is vertically equal or more than 4 millimeter, or like you defined it in the soft tissue, the irregular contour, so these even did worse than there was the others. So and it's really impressive how much difference. So we're talking about 5-year overall survival and disease specific and disease-free of 95, 97, and 90% if you don't have extranodal, versus almost a third worse, 64%, 71%, and 65% only once you had extranodal. Curious, how does that compare for the HPV negative group? Is it also very similar that once you have extranodal is significant?
Yeah, for HPV negative group, the extranodal extension, it is a very significant prognostic parameter. That's why it's incorporated in the AJCC. And there is difference in survival. However, the cutoff for major and minor is different. It's like 2 millimeter. Although the cutoff, it was not incorporated in the end stage in the AJCC, it was mentioned as an optional reporting parameter. And in our institution, we do measure the extent of extranodal extension for HPV negative, and we report that in the pathology report. And since we have done this paper, we also started to measure now the extent of invasion for HPV-positive tumors.
Wow, that's. I refer the audience to Figure 1, where you really show beautifully these definitional, vertical, the vertical span and the irregular soft tissue. So I like that figure. So it seems like you started doing it at Memorial, and I'll make sure our head and neck people start doing it if they haven't already. It sounds like should we all start doing this? It's simple enough, right? It's not that complicated. And you think based on this paper alone, you're going to be able to convince the AJCC to do it on both HPV negative and positive this time?
I think we can start with advising pathologists to report the extent of extranodal extension in their report, and I actually advise them to not to call it major and minor yet. It's just to measure it as a continuous measurement, and because that will allow us to collect the data and do more study in the future to validate this study. But I think the consideration should be given for extranodal extension to be adopted in the next AJCC. Hopefully, we'll have more data and more paper to confirm and support our finding.
Sure. If we several institutions and a lot of people start doing it, the next step, albeit it will be, you can argue even, it'll still be retrospectively, but you can do a multi-institutional and see if it still holds off. Although 232 is not a small number, so I'm hoping this is real, and this is really will help our patients. So as far as the surgeons now that you're doing, or the oncologists, you tell them somebody, because these, again, were no neoadjuvant therapy. So you tell them, okay, we're finding a significant or more than 4 millimeter or whatever extranodal. Is that impacting? Are they doing adjuvant therapy earlier? Or are they playing? Is this affecting the management, basically, in your institution?
Definitely, the presence of extranodal extension is affecting the management in our institution. The extent of extranodal extension, on the other hand, I think it varies among, depends on the situation. But if it's focal and they might not treat the same as if it's like major. So we do like measure it and we do report it in our pathology report, but I think it's the significance of the extent still varies among surgeons or oncologists, but definitely the presence of extranodal extension is important.
Excellent. Well, thank you. What a nice study. And it's amazing that when we do it well, even a clinical pathologic and histopathologic pure study without all these bells and whistles that we usually do can be that impactful and lead to such important findings. I'm sure you have in mind other studies to do it by AI or to do it to see the molecular correlations, if any, and PDL and what have you down the road. So.
Yeah, no, definitely. There are more study in the future, but we do need these clinical pathological correlation studies as well.
Absolutely. Well, thank you very much for coming today, and I look forward to follow-up papers and more contributions from you and your team. And I know you mentioned that, but Benshu and Ron Hussain, in addition to probably 8 other great pathologists, contributed to this work. So congratulations to all of them.
Thank you so much.
Thank you.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Springer Nature, UAB, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. Producers are Christina Crow, Amber Jackson, Dr. Sarah Jang, and Dr. Catherine Ketchum. Technical direction is provided by Kaminsky Productions, music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.